Good morning, everyone. This exercise is prepared as a facilitator's guide for evaluation of rationality of a fixed dose combination, an exercise for undergraduate and postgraduate students. The case taken here is a fixed dose combination of omeprazole with domperidone for the treatment of gastroesophageal reflux. Objective of the section are to emphasize the importance of rationality of fixed dose combinations and how such exercise would promote rational use of medicine, and to plan and prepare a session on evaluation of a rationality of few fixed dose combinations, and to conduct and provide hands-on experience to learners for skill development. The characteristics of fixed dose combinations are well described at many places. That at least two drugs in combination should have a complementary, maybe similar or dissimilar mechanisms of action in a combination. Second characteristic is that individual active pharmaceutical ingredient API contributes to enhanced efficacy and enhanced safety, increasing the spectrum, increasing the potentiation action, or boosting the effect. For example, ritonavir will boost lopinavir when given together. Fixed dose combinations also ensure that effective combined drugs are given where they are required. There are many diseases where single drug doesn't work, and here there is a role of fixed dose combination, in particular treatment of tuberculosis, HIV infection, and malaria. In addition, fixed dose combination should be well tolerated, of course. Now, there are limitations of fixed dose combinations. One is increased cost. Often irrational combinations are made where, for example, a vitamin is added with neuralgics, and combination may not have been tested very well, but the cost increases. Use of unnecessary additional drug when one was enough. Fixed dose combination should be considered as a new drug, and therefore carefully controlled trials are lacking for many of them. Of course, there are some drugs where such trials have been done. Dose adjustments may be difficult because two drugs are there and they are in the fixed doses. To avoid this, the manufacturers supply combinations with different distance. That means FDCs with different distance. There are 4 variants, 2 variants, and that makes prescribing more cumbersome. Despite pharmacokinetic similarities, changes in the renal and hepatic function may actually alter the pharmacokinetics differentially of the APIs. Often patients with chronic diseases require many drugs, and many of them are prescribed as fixed dose combinations. There is a risk of duplication, and there is a risk of occurrence of adverse drug interactions and reactions. Very few fixed dose combinations are explained on the basis of pharmacokinetics and pharmacodynamics, and very few are actually tested as compared to the available in the market. Now, only those are considered as rational where well established evidence is there. Some of the examples of rational combinations can be combined oral contraceptive pill, co-trimoxazole, co-amoxiclav, co-levocarbidopa, altimether with lumefantrine. There are many more, they are just representative samples. Now, this should be emphasized that many of the fixed dose combinations have equivocal evidence of efficacy and safety. Therefore, analysis has to be done to find out the rationality of such. A rational combination should meet at least following criteria: increased efficacy, greater safety, complementary mechanisms of action, pharmacokinetic similarities and compatibilities, reduction in the total cost of therapy, and appropriate use of doses in fixed dose combination, preferably listed in National Essential Medicine List or WHO list of essential medicine for adults, and banned drugs should not be there. Now, how to construct a rationality evaluation? Suggested steps are: identify the mechanism of action of API and whether one complements to the action of other or not. Second, ascertain the appropriateness of doses of individual drugs as per the guidelines, textbooks and recommendations. Third, compare the pharmacokinetic profile of individual APIs and fixed dose combination. Collect the evidence of efficacy and safety from the reported literature. Now, this is most important step. Unless there is enough evidence according to the hierarchy of evidence, preferably meta-analysis or systemic analysis, randomized controlled trials, comparator trials, non-comparator trials, case series, case reports. So this is very important step. And then find out the unit cost of individual APIs of a fixed dose combination and total cost of fixed dose combination and corresponding total cost of the therapy for a given period of time. And finally, quantify the rationality of the fixed dose combination by using these inputs and using at present review of literature states that no acceptable standardized assessment system is existing, but two are in vogue: a tool of scoring system and tool of semi-quantitative system where gradings are given. Now, scoring ranges from 0 to 14, and it is stated they are weighted also. And second is semi-quantitative, where rational, semi-rational and irrational. You can understand the difficulties in identify a semi-rational for therapeutics. Now, three scoring systems I have tried to compare. One is from Panda et al., second is from Shah et al., and third is from Dalal et al. Now, they have given a number of points, which are 7-point scale, 8-point scale, or 7-point scale. Total score counts 14, 12, or 9, and grading system has been used in Dalal et al. And actually, the position on the scale is used by Panda et al., but rational versus irrational cutoff has been used by Shah et al. The other points are relatively common among these three. Now, taking the case of PPI with prokinetic for the treatment of GERD, PPIs are considered to be more effective and standard treatment for the treatment of GERD, and they are more effective compared to H2 receptor blockers. Omeprazole 20 mg is usual dose, but 40 is also used. Esomeprazole is considered to be more effective but more costly. A prokinetic drug is added to these drugs. There are many other PPIs used I have not considered. The prokinetic relieves symptoms of the GERD but is considered less effective alone as compared to PPIs or H2 receptor blockers. Domperidone is one such drug that is preferred because of its peripheral D2 antagonism on upper GI and increasing the tone of lower esophageal sphincter and increasing the propulsive forward movements of the stomach. So usefulness in GERD is there. The drug is well tolerated, least likely to cause extrapyramidal reactions because it does not cross blood-brain barrier. We know the chemoreceptor trigger zone is outside blood-brain barrier. However, it has a lower seeding effect. Therefore, a maximum dose beyond which more effect is expected. Now, let us now collect the evidence of efficacy and safety from the available literature. Two meta-analyses, including 11 and 12 RCTs, show that ADRs are similar and Omeprazole with domperidone is more effective in reducing reflux episode symptoms and acid time and GERD score. Therefore, this is evidence in favor of fixed dose combination. In an open label non-competitive trial, it has also shown that there are improvement in the GERD symptom, but this trial is non-competitive, therefore it may not be even considered. Whereas post-marketing trial shows that this combined therapy has a greater efficacy on symptom control as compared to omeprazole alone. In a comparative trial somewhere around 2020, domeprazole in combination with omeprazole was not superior to omeprazole alone. So there is no more efficacy with combination. But in a non-comparative symptom control trial, Omidom was found to have a greater benefits. Therefore, overall, it can be in studies. I have not included many more, but overall, looking to the meta-analysis of the large studies, RCTs, it can be said there is a result in favor, evidence in favor of use of omeprazole with domperidone in GERD. Let us compare the cost. The cost analysis of the available brands shows that total FD cost is 7, whereas total combined cost of two drugs is 11 rupees. So overall, per day cost difference of 4 rupees, and if it is used for 3 to 6 weeks, one can also find out the total cost of therapy. Therefore, FDC is cost. Now, using these inputs for omeprazole and domperidone, using Shah et al. Tool for assessment of rationality, what is that omeprazole plus domperidone in fixed dose combination of 20 mg and 30 mg domperidone extended release achieves a score of 10 of the total 12. Therefore, it as the rational combination for the treatment of moderately severe GERD symptoms. Now, these conclusions should not be replicated for mild disease or extremely severe disease. It is only for the purpose of indication where such rationality will be well. More exercise can be made to apprise students, undergraduates and postgraduates, how rationality assessment will help in achieving rational use of medicine, and it will act as a guide to good prescribing. Evaluate the rationality of fixed dose combination of tamsulosin with dutasteride in the treatment of BHP as against another exercise. Evaluate the rationality of fixed dose combination of mefenamic acid with dicyclomine for the treatment of spasmodic dysmenorrhea. The postgraduate may identify two drugs which can be formulated as FDC for the treatment of constipation prone irritable bowel syndrome. Here a full exercise can be done by postgraduate as a learning experience how fixed dose combinations can be developed. So so many references are there. Thank you very much. I hope the faculty and the facilitators will utilize this session for planning a good section on FDC. Thank you and good day.